Hello, everyone. My name is Zoe, and today my partner Shail and I will be doing a case consultation presentation on schizophrenia. So we'd like to start our presentation telling you all a little bit about our client. Her name is Bev, and she is doing an initial assessment with us being a social worker at an outpatient mental health clinic. So Bev is a 31-year-old white woman. She's currently unemployed. And then she says that she grew up in Illinois, living with her parents and having a normal childhood. She started at 15 years old having symptoms of psychosis, which we'll be getting into in just a moment. Um, Eventually at not a specific age, but after high school, shortly after high school, Bev was hospitalized due to these symptoms of psychosis, which she then began taking medication to help better regulate these symptoms. And then she reports that she's currently been seeing a psychiatrist in present day for several years. And now with Bev's behavior, starting with her past behaviors and kind of what has led up to the present. Bev started to have delusional beliefs at 15 years old. She was convinced that somebody was out to harm herself and her friends, and that she needed to keep a bottle of shampoo and washcloths nearby herself as a form of protection. Like she thought that was how she could then protect herself from this person or entity. She wasn't sure who this person was, but she was had these beliefs and these delusions. Additionally, around the same time that this started, Bev began socially withdrawing from friends and family, kind of self-isolating. She reported having low mood and low energy during this time. Also anhedonia, meaning that she was not seeing or she was not doing activities that she used to find enjoyable. She wasn't finding the same enjoyment in these activities. Additionally, Bev then began using substances. She reports that she began drinking and using marijuana pretty much daily. Around the same time, her school performance dropped, and she says that she barely graduated high school. And soon after high school, she began having compulsions to self-harm in order to prevent the person or the entity that was wanting to harm her. So self-harm was a way to prevent that from happening. Um, so again, further delusions. She was then it eventually got to a certain level where her parents took her to an emergency hospital, and she was hospitalized for a time and started on medication. Which leads us to present day. Bev is doing this initial assessment with us. She says that she's been seeing a psychiatrist for several years. She, during our mental status examination of Bev, she did arrive on her own, alone, to our clinic and used public transit to get here. She appeared disheveled in her appearance. She did seem, however, well-oriented to time, place, her surroundings. As we did the assessment, she had a flat tone and slow speech, and also reported that she was having a low mood, and felt sad. Um, with this, though, she did deny having any thoughts of self-harm or thoughts of harming anybody else. And then also during the assessment, she presented with tangential thoughts and hallucinations, with her main concern being that she was fearing somebody would come after her if she did not complete a series of tasks. So with all that said, we know quite a great deal about Bev, but there are certain aspects that are still fairly unknown that we would want to further explore during our time working with Bev in order to best treat her symptoms. So starting with her employment, we know that Bev is currently unemployed, but we don't have any knowledge of her past employment. So has she ever held a job? Has she ever been laid off from a job or quit a job due to these symptoms of psychosis? And just what her employment has ever looked like, if she has ever been employed. Additionally, with her personal life, Starting with her housing and living situation. It was mentioned that Bev grew up living with her parents throughout high school, but then after that, does she still live with her parents? Because there's about a decade in between now and in the past in high school that we are kind of trying to piece together a little bit during this. So does she still live with her parents? Does she live on her own? Does she have roommates? Live with friends? Just kind of what that living situation looks like. And then further with that, also her support system being, it seems like in the past it could have been her family, but possibly friends before some of her psychosis was happening, maybe during as well. Just kind of getting a better understanding of what that support system looks like. We know sees a psychiatrist, so there's definitely that as a factor of support as well. But just understanding better what her strengths are when it comes to support system. And then lastly, under personal life, we would also be looking at her current substance use because it's mentioned that she was using marijuana and drinking fairly often in the past, but we don't know if she still continues doing that at that same frequency, or if she uses more or less of any of these substances, or any different substances. And so we want to have a better understanding of how that plays a part in her symptoms and how that affects her life as well. And then for her medication, we know that she is currently seeing a psychiatrist. She was seeing one after being hospitalized for medication management. But we would like to know more about if she consistently takes her medication, if she adheres to that proposed medication regime, and if she's ever had success in entering like a remission period after the psychotic symptoms started, or if they've been ongoing regardless of medication. Further, if she's ever switched medications, how that looked and went, and really just what her episodes have looked like, or if it has been pretty consistent symptoms, and then length of episode, how many total, that kind of thing, just to have a better understanding of what this has looked like long term. So we would definitely want to explore more with that, excuse me, both with additional assessments and just further conversations and interviews with Bev. That said, we still did settle on a diagnosis of schizophrenia for Bev, seeing as she really met most of the criteria for schizophrenia diagnosis. We used the DSM-5 to pull the diagnostic criteria that we used, of which these below or these presented symptoms, she would have had at least two of these symptoms for at least 1 month. And so we went into her delusions. That has been seemingly pretty consistent that she's had these delusions of somebody wanting to harm her. And then also it's said that she has hallucinations. We don't know a whole lot about what that looks like, but it is mentioned that that's part of it as well. Further, she is presenting with disorganized speech, which is shown with that tangential speaking. And so she gets derailed in conversation easily, that kind of thing. And then additionally, the negative symptoms that we've mentioned as well. So the low mood, flat affect, uh, unkempt appearance, all of those can be considered negative symptoms. And then when it comes to the level of how much these symptoms disturb her daily life, there's clear disturbance to her work. She's currently unemployed, and then in high school she struggled to keep her grades at a passing level after these symptoms started. And then her personal life seems affected because of that asociality during the initial onset of these symptoms, and self-isolation from her peers, that kind of thing. And then lastly, self-care is potentially questionable with her unkempt appearance on this initial assessment day. Lastly, with this, her length of the current episode, it isn't fully known how long the current symptoms have been happening. If there was ever a time in this past like decade between high school and her current day self where she was symptomless, but basing it off of her high school experience when she had at least months, if not years, of these symptoms, it's safe to say that we can rule out any short-term psychosis due to the length of these episodes, at least in the past. And then with that said, her differential diagnoses, we wanted to rule out any disorders that have overlapping symptoms with schizophrenia. So we first looked at schizoaffective disorder, major depressive disorder, and bipolar disorder, all of which are mood disorders, or at least relate to mood in their diagnosis. And with Bev, she does have those reports of low mood, potential depression symptoms, but with the intensity that is at least reported that we can reference, it seems like the intensity is fairly low compared to the other delusional symptoms and all of that. So based on this, and then also that the mood changes originally happened after these delusions began, we decided to rule out these first few disorders. And then second, the substance-induced psychotic disorder was ruled out because Bev started using substances after the onset of these symptoms, or at least that's what she's mentioned. So we ruled out any substance-induced ones. And then lastly, OCD, obsessive compulsive disorder, was ruled out because Bev does have these compulsions to self-harm or complete tasks, but they're all for the sake of preventing harm to come from herself from whoever she thinks is wanting to do her harm. So the level of delusion and also it being accompanied by hallucinations and the negative symptoms lets us rule out OCD because OCD would be largely just those delusional based like compulsions and not including all these other psychotic features that Bev is displaying. Next, we're going to see Shail get into cultural considerations.
So some cultural considerations for Bev could be just overall, some cultures may have different interpretations of the symptoms that Bev has with schizophrenia, so hallucinations and delusions. So some cultures may view hallucinations and delusions or voices in their head as like spiritual experiences instead of, a mental illness. So they may take different approaches to, getting help, which may be a spiritual healing instead of, or a holistic approach instead of, going to see a psychiatrist or going to the hospital. And another one is treatment preferences. So, views towards medications always different within within different cultures. So every culture does not view as medication as the best solution. Again, they might take a spiritual route to getting help with voices in their head, and also just views of medication in general that Bev may have, as a woman in society. That stigma of going to seek help or even taking medication for a mental illness such as schizophrenia can bring more so shame because some cultures like Asians, Hispanic, and African cultures view medication or the stigma of mental illness as a source of family shame. So that's just another cultural consideration. And the last one, cultural communication styles. So, not really knowing, having a lot of information on her household growing up, other than she had a fairly good household. Not knowing how her family communicated with each other, it could also play a role. She may have described some of the symptoms when she was younger, not knowing, her style of communicating with her family. She probably didn't, verbalize the symptoms the way that it would be in a DSM-5, as a psychiatrist would be able to diagnose her, where her family might misdiagnose her and go seek, the wrong forms of treatment, which is, likely in different cultures as well, where they will run from treatment and going to get diagnosis where they may say it's just, you know, I'm tired or anxiety, and it might be, schizophrenia. So And so this client map kind of breaks down, her diagnosis and her objective treatment, which is to overall decrease her hallucinations and delusions and just improve her emotional, regulation. Um, and using certain assessments, which is the brief psychiatric rating scale and the Columbia Suicide Severity Rating Scale. Both can be used to assess her tools for monitoring her psychotic symptoms and suicide risk in her time in seeking, assistance. The brief rating scale basically is used to rate the severity of her symptoms. So just to measure the likelihood of her medication and her psychiatric visits. Are they actually helping her delusions and hallucinations? Are they helping, her improve her everyday living, her social functioning? Her thought disturbances, it assesses her thought disturbances, her anxiety, depression, hostility, any type of negative symptoms, it kind of just assesses those. And usually the higher scores means a greater symptom of the severity, and it's just used to track, the progress over time. And the Columbia Suicide Severity Rating Scale is used to assess any type of suicidal risk that Bev may have. So typically each psychiatric visit we would give her this assessment, so it would assess the suicidal ideation intent, her plan, and her attempts, and scored on mild risk, moderate, or higher level if she's actively planning. And this was just because of her history of her voices telling her to commit certain actions or having those suicidal thoughts. And then we're the clinical social worker, so that would be, I think, the most sufficient physician in her visits when she comes to the psychiatric clinic. Um, but other physicians, who actually have higher degrees may, actually give her the medication. We would just refer those medications. And of course, a location of treatment, her outpatient clinical setting would be best for Bev. I did notate just in the case study that she did take public transportation. In that, I don't know if that might be a barrier for Bev, but we will keep that in mind in the beginning when she went to the hospital, when she had her, delusions, hallucinations. Her parents took her to the hospital where now she's taking public transportation. So just keeping that in mind, but the location of treatment would best serve her in outpatient and clinical setting. Um, and just using the interventions of cognitive behavioral therapy, pharmacological, assertive community treatment, intensive case management, which I will further, discuss later on as her interventions that she could use. And overall, we're just trying to improve her outcome long term. She's been going through this since she was in high school. So the overall goal is to um, improve that long term, goals and just decrease those hallucinations and delusions. Individually, she'll be seeking therapy, but if it fits, her in the future, family support, I think will best help her in her journey. Just family in general, that support, having that social support, and just improves those likelihoods of a better outcome for her in her journey dealing with shame, not really knowing the root of her choosing to, choose substances in the past could also help, the clinicians to better assess like her reason for choosing the substances that may also um, worsen her symptoms with schizophrenia as well. On a weekly, monthly basis, depending individually or family, it can start off weekly, her coming to the psychiatric clinic weekly, just as her symptoms are, and then with hopes that she is improving, that it goes monthly. It just depends on, Bev's, day to day. Medications, antipsychotic medications. So risperidone and olanzapine is two medications that are used, second generational medications that are used for clients with schizophrenia. Not knowing the medication that she's on, um, But with medical adherence, that also improves the likelihood of her improving overall. And then psychoeducation was another service that can be included with her treatment plan, just educating her family, if they were to be involved in her journey as well, will also play a big part in her likelihood of just getting out of that, not knowing if she's in that bubble of shame, but also just knowing if there are other family members or generations that dealing with this mental illness or have dealt with this illness, can also bring light to the mental illness where they can nip it in the bud when when they're younger, rather when they get older and the symptoms worsen, especially if substance abuse is also an issue within the family, just not knowing that. I think that psychoeducation is very important, and overall her likelihood of improving just depends on her adhering to her medication, having that social support, and being self-aware and knowing the inside of her mental illness and awareness of her symptoms and her need for treatment. I think that's the likelihood of her just overall getting better. And then the interventions, so these are a few interventions that we came up with to best serve Bev. So the cognitive behavioral therapy, this basically just reduces the stress associated with the hallucinations, not really knowing if the voices are real, if the people are real, and delusions. In schizophrenic clients, usually this approach of therapy usually helps them reduce that stress overall. It kind of is a cognitive reconstructing in their minds, and will help Bev reframe those delusions and improve her reality, on a day-to-day basis. And overall, it reduces the conviction in delusional beliefs overall, to not feel shame, to understand this is just a voice in my head, and can help her to have those, day-to-day social, interactions with her family and her friends again. And also, this approach definitely helps with that coping, and her reduced from distress. And if she were to go back to, wanting to use substances, I think overall this helps with that too as well. And then we have that pharmacological therapy, which is just her adhering to her medication. It's just that medication for those psychotic symptoms. Also can prevent relapse. Depends if Bev was ever in deep into her substance abuse, and she needed some type of medications to help. They have injections as well, that certain clients with substance abuse disorders take and use when they go to, like, in some locations we call it MAT services, it's MAR services, where they go and get injections just to help them reduce that urge to want to use any substances or drink any alcohol or whatever. So, and also the most important, the second generation antipsychotic with Bev's symptoms would basically help her. And she adheres to this, like I said earlier, it would basically help her, the likelihood of her improving. And of course, Bev would start with the low dosage, depending on what she's on already. We don't have the information completely, but if she starts at a low dosage, if she needs a higher dosage, we would just refer, for her dosages to be increased or decreased. And depending on if she's diagnosed with schizoaffective disorder, they have mood stabilizers for that, which basically adjusts the moods on fluctuations and helps manage those depressive episodes that Bev may have sometimes. Um, and also just keep in mind with that, with this approach, just also monitoring those side effects, because the medications do have side effects. That's another thing with the pharmacological therapy. And then we have the assertive community treatment that we chose to use as another approach, which is basically it provides that comprehensive care in Bev's community to promote that independent living. So to help her when she does decide, because she's unemployed, she's using public transportation, just to provide that stability for Bev and to help her manage her medication, housing assistance, provide that 24/7 crisis support. Those are like on-call mental health services that Bev may need when, psychiatric offices are closed. This is kind of that community approach that Bev could use not having if she doesn't have that family support. Um, Along and employment and vocational support as well. So helping her with that employment and encouraging her to get back into society and, you know, getting employed. And then we have the intensive case management, which basically just addresses the social determinants of, the housing, finances, daily living as well, improves functional independence. So that's just one of kind of correlates with the assertive community treatment, but this is a more individualized, support plan for her. It also includes some substance use screening and support if she were to, relapse or help her with that. And then just daily living skills and training, every time she comes and visits. That's just to improve that self-sufficiency and quality of life overall for Bev. Yeah.